So good morning, good afternoon, or good evening, depending where you're joining us from. Welcome to today's webinar. My name is Laura Ceci Galanos, and I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization that provides stroke education to health professionals worldwide. As always, it is with great pleasure that we are hosting this educational activity today on the topic of advancing the management of spasticity after stroke. We have exceptional speakers that agreed to be sharing their expertise with you on this topic. And this activity is funded by an unrestricted educational grant by Ipsen, and we'd like to take this opportunity to thank them for their continued support. Now, before we introduce today's chair, today's moderator and speakers, we're going to have a quick look at some of our housekeeping rules, as per usual. We welcome any questions you might have throughout the webinar, but we kindly ask you to use the Q&A box for those in your Zoom control panel. You can, of course, use the chat box as well to say hi, leave your comments, or tell us which country you're joining us from today. We also invite you to participate in our polls, which will be launched before and after the presentations. A reminder, of course, that the webinar will be recorded, and the recording link will be sent out to you via email shortly after the webinar, and it will also be uploaded on the World Stroke Academy site. And lastly, we kindly invite you to fill in the evaluation survey at the end, which will pop up on your screen, to share your feedback with us, which will also give you an opportunity to request a certificate of attendance for today's webinar. Now, without further ado, let me introduce today's chair and moderator, Professor Dr. Gustavo Saposnik, who's the Associate Professor in the Department of Medicine at the University of Toronto and the Editor-in-Chief of the World Stroke Academy. Welcome, Gustavo. And Dr. Shamala Thilarajah, Senior Principal Physiotherapist at the Singapore General Hospital, Associate Professor, the Health and Social Sciences Cluster of the Singapore Institute of Technology, and the President of the Singapore National Stroke Association. Thank you both for being here with us today, and Gustavo, the floor is all yours.
Thank you, Laura, for the super kind invitation, and welcome everyone. It's a great privilege for me to be a co-moderator with Shamala. So we have a very interesting presentation today, and let me do a brief introduction about this critical and important topic. And by the way, when we ask you to please participate and ask questions at the same time, you will get the certificate provided that you are completing the evaluation at the end, and you may have the handouts. So why this is important, and I'd like to start with my last slide, which is acknowledging the support of Ipsen. Otherwise, this wouldn't be possible. Secondly, I'd like to acknowledge the commitment and volunteer work done by the speakers. They receive no compensation for doing this, so thank you all. And to Laura, who put together, all these webinar and organizing and managing operations for the WSA and the communications as well. So why this is important? As you know, 1 in 4 stroke survivors have a spasticity or are living with the spasticity. This is not an uncommon phenomenon, and unfortunately, we know that 70% or more of physicians have some therapeutic inertia. What does it mean? That we do not initiate or intensify treatment when the target goals are unmet. So this is an important concept measured in multiple conditions and worldwide. This affects 1 in 4 therapeutic decisions, usually. And finally, again, is something that is important and probably will come up today, is about the misalignment of expectation between patients and the specialists. So I will turn towards my co-moderator, Shamala. So she will be doing the introduction of the speakers. Thank you very much, and all the best.
Thank you, Gustavo. And welcome everybody to today's session. I'm also very pleased to be moderating the session with Gustavo and with all the speakers today. So our first speaker for the evening or morning or afternoon is Emily Stevens, who is an occupational therapist and also a certified stroke rehabilitation specialist for the stroke recovery research at UT Health Houston Institute for Stroke and Cerebrovascular Disease. And she's speaking today on spasticity after stroke treatment intensification amongst patients with unmet needs. Over to you, Emily.
Thank you so much, Shamala and Gustavo. Let me get my screen up. And there are a couple poll questions that are going to be up on your screen. If you guys will go ahead and answer those.
Okay, thanks, Emily. The first poll has been launched. And the question is, who plays the largest role in management of spasticity? And you have 4 options there: the stroke survivor, the caregiver, physio or the occupational therapist, and PMR. So please launch your answers. Thank you. And the second poll is, spasticity has no impact on functional recovery, true or false? Okay, thank you, everyone.
Okay, thank you everyone for joining us. I'm really excited to be here with you. It's very early in Houston. It's 7 o'clock in the morning here. I appreciate the introductions, and I'm really excited to talk on this topic. As I was preparing my slides, I realized that I could probably talk to you all day, but unfortunately I can't do that. So I'm going to try to stick within my time. Just briefly, the learning objectives for the webinar that I'm going to be addressing today are the innovative approaches to intensify treatment of spasticity, adapting spasticity management for special populations, as well as the importance of the multidisciplinary collaboration. But before we get too far into it, we must define spasticity. And historically, spasticity has had multiple different definitions. The one that is most recent and I believe most relevant for our post-stroke population is that spasticity is an involuntary muscle activity in central paresis that is affected by slow or rapid passive joint movement, as well as sensory stimulation. And I've highlighted sensory, or I've underlined sensory stimulation here because this was very frequently left out of previous definitions, but for this particular population, it is very important for us to keep that in mind. And I'll touch on that a little bit later. Like Gustavo mentioned, spasticity is present in at least 25% of stroke survivors and 40% of stroke survivors with paresis. Of that 40% who have paresis and spasticity, almost 10% of that develops into a severe or a disabling spasticity. I want to point out the graphic here on the right side of the screen. This is from Lee et al., which I do have listed within my references. I'm not going to go into detail about it, but I do highly recommend that you look into this article, you review this graphic and the information that they have about it, because it is a very good pictorial representation of what is happening within that feedback loop that is impacting the involuntary muscle activity within a stroke survivor. So why should we focus on spasticity? What's important about this? Of course, as an occupational therapist, the first thing I want to talk to you about is the functional impact. We very frequently see spasticity impacting the function of stroke survivors, whether it be with their daily activities, anything from their self-care to returning to work, or with their ambulation and their mobility. In addition to the functional impact, we also have concerns in regards to hygiene. So we very frequently will see in the axilla and the elbow crease, or with a closed hand, or even with someone who has adductor spasticity, within those areas where the spasticity is causing that involuntary muscle contraction, there's going to be a crease. And within that crease, moisture will build up if we're not able to clean, if we're not able to keep it dry. And this over time can lead to macerated skin, which over time can lead to wounds. And that's obviously something that we want to avoid. We don't want to cause more issues for our patients. In addition to the hygiene concern, pain is also a huge factor when it comes to spasticity. It's very frequently reported by stroke survivors. And when we think about it, if you think about an involuntary muscle contraction, if you think about your muscle pulling all the time or being triggered to pull and you can't control it, that absolutely sounds like it's going to be uncomfortable. Over time with spasticity, it can impact posture. That ongoing pull of a muscle can impact the tendon, the muscle, and the ligament length, which of course leads to more pain. With that change in posture or that ongoing pull, it can also lead to nerve entrapment within the joints where the spastic muscle is crossing, which of course can contribute to even more pain. And I know that's something that Dr. Dishman will talk about later today. So how do we address spasticity? We have to address it as a multidisciplinary team. And you'll see here on this slide, I'm not just talking about the medical team, the physicians, the therapists. I'm also talking about the family and the caregiver. But even more so, I'm talking about the stroke survivor. The stroke survivor is at the center of that multidisciplinary team. And over time, they're the ones who are dealing with spasticity in a longitudinal way. As far as rehabilitation interventions, which is what I'm here to discuss this morning here in Houston, we think about it in 3 categories. So education, positioning, and physical intervention. But what I really like to think about is that at the center of this Venn diagram, that's where the most important intervention occurs, that combination of all of these categories. So when we think about education, we're thinking about education for self-management. Like I mentioned, the stroke survivor is the person who is managing their spasticity longitudinally. So it's very important that education begins early, that it is consistent across the continuum of care, and that education occurs often. Repetition is very important. There's a lot of overlap between what we're educating them on and some of the physical intervention. So I won't go into a lot of detail on the bullets under education, but things like exercises, stretches, positioning, and then identifying triggers. So like I mentioned earlier, post-stroke spasticity absolutely has a sensory component. And it's very important for us as clinicians to be able to facilitate the identification of triggers with the patients that we're working with the stroke survivors, because that helps as far as the moderation of the spasticity. Physical intervention is, I'm going to focus the most time discussing this today, but some interventions that are very important. So active and passive movement. Actively being able to move within the range that is available, and then passively being able to assist the stroke survivor to get past that movement where the spasticity is stopping them. This is really important because we want to make sure, like I mentioned before, we're thinking about it preventatively. We want to make sure that we're doing everything we can to prevent the loss of the length of that muscle, the tendon, the ligaments. Weight bearing is another very important intervention, and weight bearing can look a few different ways. Some of my favorite interventions for someone who has spasticity throughout their body is getting them into quadruped, getting them onto hands and knees, if at all possible. Sometimes you'll need supports for that, and that's absolutely fine, but getting them into a heavy weight-bearing position is inhibitory to that spasticity, thinking about that feedback loop, and it sends those signals back to the brain to try to relax those spastic muscles. Weight bearing can look a lot different for the upper extremity or the lower extremity. Anytime that you are transferring, anytime that you are walking, you are going to get some sort of weight bearing through the affected lower extremity. With the upper extremity, we have to get a little more creative sometimes, and that can look like positioning the arm on the table while someone is eating. That can look like doing something and standing, doing a functional task, and doing weight bearing through the hand on the kitchen counter. There are multiple different ways to think about. Strengthening is another very important intervention, and this is something that historically was considered a little taboo in spasticity management. And the reason being is that there was concern that we are strengthening the spastic muscle itself. But strengthening in the way that I'm going to discuss it is very important when we're pairing it with chemodenervation, and then also incorporating electrical stimulation to facilitate. So the chemodenervation is going to relax that spastic muscle. It's going to limit that involuntary muscle contraction. And then we don't want to just strengthen the antagonist that is going to work against the spastic muscle. We want to also be able to strengthen the volitional control of the muscle that has spasticity, so that we can have a stronger muscle when the spasticity returns to hopefully fight against that spasticity. A prolonged stretch is very important. When we think about the typical positions that we see spasticity coming in, the flexor synergies, we're getting further away from that full range of motion, and we're getting further away from the anatomical position. So putting someone into a prolonged stretch paired with some positioning devices is very important to prevent the change in muscle length. Aquatic therapy is another very beneficial intervention. Aside from the benefit of warm water, which is typically somewhere around 90 degrees in Fahrenheit, around 32 degrees in Celsius, but aside from the warmth of that water, which is inhibitory to spasticity, being in the low gravity environment is very beneficial because you lose some of those sensory triggers that you might encounter for someone who's on land. As far as positioning goes, we want to think about positioning for daytime. So for functional use, this could look like braces or AFOs for the lower extremity, and this could look like functional splinting for the upper extremity, even incorporating some sort of elbow block to make sure that the elbow isn't bending up during ambulation or during strenuous tasks. At nighttime, we want to try to find that middle ground between positioning to prevent loss of muscle length, but also making sure that we're not impacting sleep integrity, because we know that's very important from the healing perspective as well. Serial casting is a topic that it could be its own webinar. So I'm not going to go into detail, but there's a lot of literature that's out there. So if this is something that is new to you, please definitely look into that as a beneficial intervention. So when we think about our patients with unmet needs, how do we take those interventions and how do we help intensify their therapy, and thinking about therapy from the longitudinal aspect? The first thing I want to mention is that stroke survivors in the chronic stages need intervention too. So whether they're having a delayed onset of their spasticity or whether they've had spasticity along the continuum of their care, it's very important that we're not forgetting about the subpopulation of stroke survivors. Here in the US, we frequently see people who are coming to us on the outpatient or the home health side, and their payer sources may not feel that this is a new change, so they may not cover further therapy for them. And that's unfortunate because there's absolutely a role in chronic spasticity management. Again, even if we're not thinking about function, changing functional level, it's very important for us to think about prevention from some of those secondary complications from spasticity, and making sure that we're advocating for our patient population to the payer sources, and then also incorporating that education, like I mentioned before. Another thing to think about, if you're in an area that has low access to rehabilitation specialists, or even if you're in an area that from the transportation perspective, you can't get to where you need to go. Something to consider is extensions of therapists. So this could look like personal trainers, exercise physiologists, or even community health workers who have gone through a training through your hospital system or directly with your rehabilitation team. And they're taking some of that education and intervention into the home or into the community for these stroke survivors who don't have access. Another thing to think about is with telerehabilitation. So we've been doing a lot of work with telerehab here in Houston, but another way that this could be incorporated is having a therapist available via video conference and having these extensions of the therapist within the home or within the community, incorporating interventions while the therapist is guiding that and leading it. If you take nothing else from my presentation today, please please take away that education is key. So there's literature that shows that education that occurs at a single time point, or education that occurs when someone is leaving the hospital, is frequently lost within the processing system, just because our stroke survivors, our stroke survivors' families, caregivers, they're so overwhelmed with information that not everything can stay. And it's really important that as professionals who are attending to the spasticity needs of this population, that we are educating often, we are educating in repetition, and that we are consistent with the message that we're sending across the continuum of care. And then lastly, I would recommend that you think outside the box, get creative. That is something that we absolutely have to do to be able to address those patients who have unmet needs. Thinking about what resources that you have available to you, or that your patient population may have within their community or within their home, where you can incorporate those basic categories, the education, the physical intervention, and the positioning. And how do you incorporate that so that we are building that within the environment that our patients are in? Here's a list of my references. Here is my email address. I love talking about spasticity. If anyone has any questions, I'm more than happy to discuss further over email. And also, I'm looking forward to answering any questions at the end of the webinar. Thank you.
Thank you, Emily. I really enjoyed your talk, and a few things that you said about education got me a bit excited, but we'll save that till the end. I'll introduce you to the next speaker for this evening, but there is a poll prior to that. So poll number 1, who plays the largest role in management of spasticity? The stroke survivor, the caregiver, physio or the occupational therapist, and PMR. Thank you, everyone. And poll number 2, spasticity has no impact on functional recovery. True or false? Excellent. Thank you, everyone, for participating. Our next speaker is Associate Professor Kwa Lee Kim, or Kim. She is the Director of Programs for the Health and Social Sciences Cluster at the Singapore Institute of Technology. And today she's talking on management of spasticity in special populations, elderly and those with limited access, as well as those who are frail. Over to you, Kim.
Thank you, Sham, for the introduction. Let me just share my slides. Hey, good morning, good evening, good afternoon, everyone. Now, in webinar 1, we actually covered on the overall management of post-stroke spasticity. So this time around for this talk, I'll try to zone in on special populations, and I've defined them as elderly who are frail, living in nursing homes, or have limited access to treatments. And as we know, with the frail individuals, usually when they have a stressor event that has occurred to them, such as a fall or a hospitalization, they often take longer to recover. And when they do recover, it's often a lower level of pre-morbid function. And they and once they get into the frailty stage, they when they do recover, more often than not, they enter a state of permanent disability. So these are the special populations that I'll focus in my talk. The learning objectives are to be able to outline issues with spasticity management in special populations, to recognize scenarios where spasticity management is warranted, and to also summarize spasticity management in these special populations. Okay. Now, the main issues with spasticity in special populations is that we do know what to do, particularly when the stroke survivor leaves the hospital. Most people will have an idea of the type of interventions surrounding Botox, rehab therapy, and adjunct therapies. But what is perhaps less unknown or less clear will be about who and where once the stroke survivor leaves the hospital. And what I mean by that is when the stroke survivor is actually in the hospital, it's quite easy to detect spasticity. It would be one member of the multidisciplinary team. It could be the physio, the OT, the nurse, or the rehab consultant. But once they leave the hospital and they are in the community or living at home or living in a nursing home, there is no one dedicated, designated person to actually detect spasticity. It could be a family member, it could be a caregiver, or it could be a nurse or a community care staff, depending on where you're from. So the individual that is actually detecting the spasticity is less certain, and also where care will be provided. In the hospital, of course, once if it's detected that spasticity is a big problem for a patient, it will be treated within the hospital and often by a stroke specialist team. But once they leave the hospital, the question is, will they be receiving this care in primary care in the community, at home, in the nursing home, or will we try to find a way to get them back to the stroke specialist services, which are often in hospital? Now, some scenarios where spasticity management is warranted in special populations, and we have also seen some of these pointers in webinar 1. So we often ask, we are very aware that just because spasticity exists doesn't mean that we have to address it. Sometimes it's a good thing because in some frail individuals, it will allow them to be able to stand or to transfer, and that will also help with dressings. So the question that we often ask ourselves is, what are we trying to achieve if we do remove or manage the spasticity? So in this case here, it's important to keep in mind that sometimes for these frail individuals, spasticity is a good thing, and we need to think about whether removing it will actually impact on their level of function. The other thing to keep in mind, of course, is that with spasticity, it's often associated with contractures. And if the person after stroke have got quite severe contractures, which can sometimes also lead to pressure areas, and it's causing pain or discomfort, and in those cases, then spasticity management will be warranted. And also in these special populations, the most common reason why spasticity management is given is often because there's an increase in caregiver burden. So either difficulty with showering, dressing, or performing perineal hygienes. It could be some of the reasons why, and usually the Botox might be given for the hip adductors, for example, or the shoulder adductors and internal rotators and the elbow flexors. Now, there was a study that was actually done in 2020 in the UK, and what they were trying to do with this study was that they brought experts together that consisted of GPs, stroke physicians, nurses, and allied healthcare professionals. And they were trying to answer the question when referral from primary care to stroke specialist services was warranted for stroke survivors. They had set 17 different case scenarios and 69 different referral decisions that they have to make. But when it came down to spasticity management, there was unanimous consensus that it was a specialized problem post-stroke, and it must be referred to a specialist stroke service or spasticity clinic. So often referral back to the acute hospital rather than to have it managed in primary care. Now, go on to talk about the overall management of spasticity in stroke, referring to guideline recommendations. Then I'm going to zone in on the management in special populations. So here is just showing that I'll be drawing out the recommendations from 3 guidelines: the World Stroke Organization guidelines, Stroke Foundation guidelines, and the International Conference of Frailty and Sarcopenia guidelines. And these were identified to be high-quality guidelines from these 3 systematic reviews that have used the agreed-to checklist to appraise the quality of the clinical practice guidelines. So these 3, we can be certain that we can trust the recommendations that they are making. So I'll first talk about what the World Stroke Organization guideline recommendations say about spasticity. So it's recommended that Botox be used to increase range of motion and to decrease pain, particularly for patients with symptomatically distressing spasticity in the upper and lower limbs. Advanced systems here means because with the agreed to, they not only rate the quality of the guidelines, but they also rate the applicability. So under what system should you be using the guidelines, either minimal, essential, or advanced? And advanced system just means that it needs to be done in a system that has got both allied health and medical healthcare professionals who specialize in stroke. But the second point to make with this slide is that the recommendations surrounding Botox and rehab therapy and adjunct therapy, such as electrical stimulation, casting, taping, are considered weak recommendations. And you can see here that it may be used to reduce spasticity, but it's unlikely to improve activity or motor function. And it's often considered to be weak recommendation, not just because the quality of evidence is weak, but in this case here is also the fact that some patients might want it, some patients might not, and also the perceived benefits do not significantly outweigh the perceived harms. The other thing to think about also is also the resources. So usually these four factors would guide the recommendations whether it's weak or strong. But the second point to just be mindful of is that it's actually weak recommendations in terms of the rehab and the adjunct therapies in addition to Botox. Now here, because we're talking about the special populations, I've also included some guideline recommendations for frailty, because quite a lot of the individuals that we do see in these special populations are also frail. And here in this case, they have also used the grade to determine the strength of the recommendations. And you can see that most of the evidence are considered low, very low quality, but the recommendation can still be strong. Once again, if the perceived benefits are considered to outweigh the harms quite significantly, if there are very strong values and preferences for the particular treatment from the stakeholders, and also if we have the resources to actually deliver the intervention. So here in this case, they have determined quite several strong recommendations from the frailty guideline, but I've summarized them into 3 points. So the recommendation is to screen with validated rapid frailty instrument, and that could be something like the clinical frailty scale, or the frail scale, or the Edmonton frailty scale. So those are just some examples of very short screening tools to use. The second recommendation that they make, the broad recommendation, is to assess with a clinical assessment, and this would be something like a rapid geriatric assessment, which consists 4 short screening tools that look at cognition, nutrition, sarcopenia, and also frailty. And of course, the third point is to treat with comprehensive management plan. As we know, with frailty, it's often due to several factors such as sarcopenia, polypharmacy, and if the patient has some false risk factors such as reduced vision, reduced cognition. So you can imagine that because of these factors, your intervention will of course have to be multifactorial. And with an exercise program, it's often targeting the sarcopenia. So there will be some level of strength, balance, flexibility, and aerobic training. And if you were working on polypharmacy, a nurse might be involved to actually look at the recommendations to look at the medications that might be considered unnecessary. So I think we all roughly know this, and also thanks to Emily, who covered a bit of this in her talk. We know what to do in terms of Botox, rehab therapy, adjunct therapies, and a comprehensive frailty management plan. I've just got some pictures here on the right, courtesy from the Singapore General Hospital Spasticity team. I think we've got some of the doctors and allied healthcare professionals here. But you can see that these are just some pictures of a physio applying casting after Botox was given to a patient. And this can sometimes be accompanied after the cast is removed. The treatment often includes prescription of an AFO or a toe spreader if the person has toe clawing. And then, of course, you also have your rehab therapy. You have your intensive rehab, standing or walking with the walkers, or you have electrical stimulation. And like what Emily mentioned, you would be strengthening both the muscles that was Botox and also the opposing muscles. Okay. But here I would like to zone in on the spasticity management in special populations. So we covered the what, but then we mentioned that we were less certain about the who and the where. So I think once the stroke survivors leave the hospital, sometimes it's quite difficult to figure out who should be the one to detect it and how to go about detecting it and where the care should be given. So here I've got 3 C's, checklist, connector, and connecting system. So a checklist, to be aware that there are actually very short checklists out there, one specific to stroke, one specific to clinical frailty, but I will just zone in on the stroke one. So this post-stroke checklist was developed by Philip and his team in 2013 and subsequently adapted by the World Stroke Organization, and it allows healthcare professionals, stroke survivors, and also caregivers to be able to identify some of the complications that could occur as part of long-term management after stroke. So it includes things like spasticity, incontinence, mood, and life adjustment after stroke. So this might be a good way to kickstart, particularly if you are thinking of implementing something in your service, for example, if you work in a nursing home. The second thing to think about, of course, is connector. Thinking about who is the person to actually identify the spasticities. It could be a family member, caregiver, or it could be a nurse or a physio working in a nursing home, or it could be a community care staff, depending on who is working in your healthcare system once the stroke survivor leaves the hospital. The third thing to think about is the connecting system. And I think here it's probably a lot easier to think about a way to refer back up to stroke specialist services in the hospital rather than to upskill your primary care services. And in my next animation, I'll just show here. Once again, courtesy of the Singapore General Hospital Spasticity team, they actually have created a stroke referral pathway for patients in the community to be referred to the spasticity clinic at Singapore General Hospital. And the referral pathway consists of when someone would call SORT, which stands for stroke, I think it stands for spasticity triage referring system. And so there's some criteria about when to call and when not to call, and very similar to what Emily mentioned in terms of the trigger. As we know, sometimes patients might have a UTI, or they have an ingrowing toenail or a cut on their leg, which could sometimes cause the spasticity to be more severe. So we would want to be able to address that first rather than to actually target the spasticity straight away. So these are just some of the criteria that was listed before one would call SORT. There's also a primary contact number and a name and a person to contact, and also the process subsequently afterwards when you do call SORT. So I've got 3 take-home points. So the biggest issue surrounding spasticity management, not so much the what, but in terms of the who, in terms of identifying someone to detect spasticity and determine where the spasticity management would take place. Spasticity management is warranted if spasticity is causing difficulties in activities, pain or discomfort, and increasing caregiver burden. And in addition to Botox, rehab, and adjunct, I mentioned about the 3 C's. So the management in the community, it would be good to think about checklists that you can use to identify spasticity. Think about the connector, identify the person to be able to detect and identify spasticity, and to think about creating resources or pathway to aid referral back to stroke specialist services from the community to the stroke specialist services in the hospital. Okay, and these are my references. Oops. Okay.
Thank you, Kim. There are
No
2
problems.
polls now coming up. Poll number 3, referral to a specialist stroke service or spasticity clinic is warranted for a nursing home resident with limited mobility if spasticity is causing, and there's 3 options there for you: difficulties in stair climbing, increased risk of COVID-19 infections, and caregiver burden during showering and dressing. Please let us know your answers. Thank you, everyone. And the last one. In addition to Botox A, rehabilitation and adjunct therapies, what other spasticity management strategies might be useful in special populations? acupuncture and communication pathways, post-stroke checklist and referral pathways, stretching and clinical frailty scale. Thank you. Thank you, Kim. I think I could see common themes between both Emily and your talk with regards to education, early screening, detection, and connecting people to the right places as needed. We'll go on to our third talk and keep the questions for later. Thank you to everyone who's been asking some great questions. Keep that coming. Our last speaker for tonight is Dr. Denise Dishman. She's a faculty appointment at Department of Research at Cizik School of Nursing, lead in post-stroke pain management program at UT Health Houston, Institute for Stroke and Cerebrovascular Disease. Over to you, Denise.
Thank you, Shamala, and thank you for having me. I'm going to share my screen. Okay, so today I'm pleased to be here with you to talk about spasticity therapies. The topic is beyond chemodenervation. And our overall themes for learning objectives are really to hone in on that tight coupling Emily had brought up in her talk about the sensory stimulation and the tight coupling between pain and spasticity. Not only do they share physiological pathways and mechanisms, but pain is a stimulant for inducing spasticity, and spasticity induces pain. So they're two tightly woven concepts that really need to be addressed. The other objective theme is identifying and really understanding the evidence behind these therapies that are available. So as we know, 1 in 4 stroke survivors will have spasticity. They also, up to 50% of stroke survivors will have post-stroke pain. And a lot of that pain is caused by spasticity or musculoskeletal pain. And so there's no standardized approaches to post-stroke spasticity or even post-stroke pain. A lot of the therapies, however, will cover both the spasticity and the pain because of this tight connection between the two. So before I could talk about beyond chemodenervation, I need to address what chemodenervation is. And it's really blocking that neuronal signal at that neuromuscular junction, mostly with botulinum toxin. And botulinum toxin has been used over the past 30 years in spasticity. It has two mechanisms of action, really. When it blocks that presynaptic release of acetylcholine, it's going to keep the muscle from contracting. Additionally, it will block the release of substance P and glutamate and other excitatory neurotransmitters and causes an analgesic effect as well. And so that's why we use it a lot for migraine management. And you will have analgesic effects when you use it for post-stroke spasticity. There's 2 main problems with using botulinum toxin, however. And one of them is the side effect, which is really weakening muscles that you do not intend to weaken. And so you're having a decrease in function because you have a generalized weakness in an area that you did not intend to target. And there's also a maximum amount of botulinum toxin dosage that we can use per treatment. And so if you have a large area of treatment required, you're really limited in how much that you can treat. The advent of ultrasound has really minimized much of these side effects. We used to use just surface anatomy and palpation, but with ultrasound, as you can see in the images to the right of the hand, those are ultrasound images where you can actually see the targeted nerve and muscle that you want to inject. And so not only are you minimizing spread, you're also maximizing the dosing that you're using. So it's a very good tool and minimizes side effects of botulinum. So there's been many studies and much evidence demonstrating that with the use of ultrasound, there's better reported outcomes over even electrical nerve stimulation, which is another method of isolating the nerves. There is a network analysis done by Asmikadu and Sideropoulos just this past year that looked at ultrasound, looking at the modified Ashworth scale. So it's the only actual quantitative outcome that was assessed. And they found that ultrasound definitely demonstrated a higher quantitative outcome over the other approaches. All three techniques are better than just palpation or using surface anatomy. Excuse me. So the usual dosage limit is 600 units, but there has been a systematic review trying to look at if there is a relationship with using higher dosing to improve function and analgesia. And they found that there is some relationship, but they don't have enough evidence to really demonstrate that they can conclude that it's better. So beyond that botulinum toxin chemodenervation, we have chemical neurolysis, and that is really the application of a chemical agent that goes directly on the nerve or at the motor point, and it interferes with nerve conduction through destruction of the axon. And this has historically been phenol and alcohol. It's been used for many years. It's used in pain management as well at lower concentrations than for spasticity. These agents work at the alpha motor neurons. They cause this Wallerian degeneration of the axon. So the axon degenerates, and over time there is regrowth. The benefit over botulinum toxin is that whereas botulinum, you're waiting a week for peak effect, this chemoneurolysis has a much faster onset. It's within minutes you will see muscle relaxation. The problem with this approach, however, is that there can be chemical neuritis. There is definitely pain on injection of these agents. There can be diaesthesias and resultant neuropathic pain. Again, with ultrasound nerve identification, this has been minimized, but without having a good skill at using these approaches, there is the potential for adverse events. So we move on to the other adjuvant therapies, and acupuncture gets a lot of play in the evidence. There's a lot of clinical trials looking at acupuncture, all sorts of acupuncture, electrical acupuncture, acupressure, orbital acupressure, auricular acupressure. And despite having so many clinical trials, there is very weak evidence demonstrating any effect for muscle spasticity. The reporting methods are quite variable, and the methodologies used are quite variable. A newer method is electroshock wave therapy, and this really is an interesting approach. It uses this highly energetic biphasic acoustic waves under pressure. It focuses these acoustic waves to targeted areas, and it causes the axonal degeneration as well as releasing nitric oxide, which creates an environment rich for axonal regrowth. And so there has been evidence that there is some kind of increase of function with the use of this electroshock wave therapy, but the results are mixed. And of course, there's no standardized treatments presented in any of these clinical trials. looking to other methods that have been useful in pain management and depression, symptoms very tightly linked with stroke. There has been work in transcranial magnetic stimulation, as well as transcranial direct stimulation. But both of these techniques did not demonstrate any significant change in modified Ashworth scales over sham. However, with the repeated transcranial magnetic stimulation, they did find a change over the course of treatment, but it did not reach statistical significance. Cryoneurolysis is another interesting new therapy. It's basically a freeze therapy. This is another approach that we use in pain management. There's a specialized probe. It can go to -60 to -3°C using a Joule-Thomson effect. It creates, when it comes in contact with body fluid, the tip of the probe is so cold that the body fluid becomes this ball of ice. And when you put it in close proximity to a targeted nerve, it again causes that Wallerian degeneration of the axon, and the epineurium and perineurium are not affected, and so that allows for axonal regeneration over time. And again, it's a prolonged regeneration, so you have much longer effect. The surrounding tissue is not affected because their freezing occurs at much lower temperatures than the axon. So this therapy really can give you months of therapy, like the chemoneurolysis with phenol and alcohol, without that painful injection of the phenol. There still is a side effect, potential side effect of that neuropathic pain and diaesthesia. Right now, there's an ongoing prospective study by Winston and colleagues. They have reported the adverse events in this prospective study. They've been following patients for a year post this cryoneurolysis, and they report that only 9 of their 113 patients reported diaesthesia, and it was transient. And they attribute that to really the application of this probe on a mixed motor sensory nerve. An exciting approach that's gaining a little bit of favor in the literature. It's a long-used pain therapy. It's a stellate ganglion block. This is a block of the sympathetic nervous system using a local anesthetic. It's been used for over 100 years in pain treatment of upper extremities, the neck, the face, complex regional pain syndrome, peripheral vascular disease. So it's a well-described treatment. However, historically, before ultrasound, the application of this block was performed under fluoroscopy. The stellate ganglion is located by C7, and because of the high-stake real estate in that area of the neck, including the vertebral arteries, carotid arteries, their approach was under fluoroscopy to identify C7 transverse process, hit the bone, and inject. And so, as you can imagine, there was a lot of intra-arterial injections and subsequent seizures and cardiovascular collapse. And so this block was not well looked upon until the advent of ultrasound guidance. And as you can see in this next slide, this is an ultrasound picture. Here is in the picture on the left, this white line is the needle. It's a 22-gauge spinal needle approaching the stellate, which is located between the longus colli muscle and the carotid artery. And so under ultrasound, you can really identify structures and maneuver your needle to avoid any adverse events. This is the C6 spinal vertebrae. This is the posterior process of C6. And the approach is at C6 rather than C7 to avoid pneumothorax, because the apex of the lung is very closely approximated to that C7 level. This is a patient undergoing a stellate. As you can see, it's an outpatient office procedure. There's just the ultrasound probe, I'm sorry, and the needle. The patient's head is turned away. So it's an easy approach, easy sympathetic block. And this sympathetic block, they found you can block the peripheral nervous system. It inhibits the function of preganglionic and postganglionic fibers, suppresses muscle tension. I witnessed a patient come with generalized dystonia. He had it for 2 years. They did this sympathetic block, this stellate ganglion block on him, and he had resolution of his dystonia. Again, that's just one observational case. But Young et al. Just last year looked at stellate versus extracorporeal shockwave therapy in 60 stroke survivors. Then they, had a control group, and they demonstrated that all of these therapies demonstrated improved Fugl-Meyer assessment. However, the stellate combined with the electroshock really exhibited the best outcome. She et al. Induced in a publication this past year, they induced thalamic stroke in diabetic rats, trying to replicate central post-stroke pain. And they found that the stellate actually could improve cerebral ischemia and neuronal function in these rats. And they uncovered that the main mechanism of action was this inhibition of inflammatory response and phosphorylation of NF-κB-P65. So they found that in these rats, they could improve brain blood circulation, aid the damaged brain, improve blood supply to the limbs. They relieved muscle spasticity, and promoted tissue metabolism and limb function with this block. So it was a pretty exciting discovery. So there's a large body of evidence really supporting the stellate. It's has emerged as a novel treatment in various pain conditions, including complex regional pain syndrome, postoperative pain, orofacial pain, and in autoimmune conditions, including fibromyalgia and long COVID, even relieving the long-term smell and taste issues in long COVID. For central post-stroke pain, there has been case studies that show that one single treatment has reduced pain and usage of analgesic medications. And because of that tight coupling in our stroke patients, with high reports of depression and anxiety, Lynch et al. In 2023 had a case series of 285 patients that they showed with 50% decrease in anxiety reported symptoms in patients treated with stellate. So another good application for our stroke survivors. It's used widely in the military for post-stroke, traumatic stress disorder. So the takeaway messages here are really that there is no standardized treatment. The botulinum toxin therapies are the therapies that are most widely used with imaging and other used in tandem with other therapies. It can be quite effective, but there are those dosage ceilings with the use of botulinum toxin and the side effects of weakness in muscles that you didn't intend to treat. The effectiveness of all those therapies, the injection therapies, are really dependent on provider skill and their skill in the use of ultrasound and being able to really target those isolated nerves. Adjuvant therapies are available, but the evidence surrounding them are pretty weak, and they require further rigorous trials. Most of these therapies do provide analgesia and pain management, and we know the cycle of pain inducing spasticity and spasticity inducing pain. However, additional pain assessment and management is critical in this patient population. So We talked about the tight interlink between pain and spasticity, and both of these post-stroke sequelae really need evidence-based guidelines. And here are my references.
Thank you, Dennis. There's also another poll that's been launched. What is the first-line treatment for spasticity according to the evidence? Dennis, may I invite you to comment when the reply comes up?
So it's kind of a trick question. There is no standardized first-line treatment for spasticity. So really, it's an individualized approach, as Emily and Kim have demonstrated in their discussions. There's such wide variability in our patient population and presenting symptoms, presenting spasticity, presenting pain, that anything that works for your patient is really an ideal treatment.
Thank you. And the next poll, when should pain and spasticity assessment be initiated after stroke? Dennis?
And again, you really want to look for these, looking for spasticity. The evidence demonstrates that, there are predictive factors that you can identify really early on post-stroke, and the same for pain. And so if you can mitigate these, there has been some evidence that using botulinum toxin early in the acute phase can prevent some of the spasticity, much like we use botulinum to prevent wrinkles, in that regard. So really looking as early as possible is the right choice.
Thank you, Dennis. So we'll go on to the Q&A session now. Thank you to the speakers for their wonderful presentation, and there's been many comments on the chat as well as questions. So I'm going to try and group them all together. First, I'd like to thank Angelica for picking up on my error, that it should be botulinum toxin A and not Botox, which is a brand name. So I'd like to clarify that at the beginning of this Q&A panel as well. In that vein, I've grouped a couple of questions. So this question is for Kim and Emily and Dennis as well. There's been questions around differentiating contracture versus spasticity. And are there any known quantitative tools to measure this? And what are the limitations of the current modes of assessment of spasticity, clinical assessments of spasticity? So there's 3 questions. So perhaps, Kim, you can take this first.
There were 3 questions. The first question was to differentiate between spasticity and contracture.
Yes.
Okay.
I think you could maybe round up your answer to address all 3 because it's sort of interlinked.
Yeah, it's quite, yeah. So
interlinked.
contracture is the loss of passive joint range. We usually measure it using a goniometer or just applying a stretch slowly. So it's just passive joint range. So that will help us to determine if the person has a contracture or not. Whereas spasticity tends to be defined as a velocity-dependent increase in stretch reflex. So it also means that when you apply the stretch, it has to be velocity-dependent. So we often use something like the modified Tardieu scale, which requires you to actually grade the muscle reaction to see if there's a catch or a clonus and what's the duration of the clonus. And you would do this at slow speed, V equal to 1. And then you would also do it at fast speed. You could do V equal to 2 or V equal to 3. So by using the modified Tardieu scale, you can just do V1, which is similar to passive joint range. By using it, it will help you to differentiate between spasticity or contracture.
Thank you, Kim. Emily?
Kim took the words right out of my mouth.
Yeah.
Another thing that I would like to add is that we also frequently, and I mentioned serial casting just briefly, but serial casting is another way if you're not entirely sure, but you do have the opportunity to actually incorporate serial casting into the plan of care. If that works with your payer source, if that works with the plan of care that you have with your patient. There's evidence that shows that after 2 weeks of consistent serial casting within the guidelines for it, that if it is a contracture, of course, it's not going to change. If it is potentially a beginning stage of shortening, but it hasn't become a fixed contracture yet, that you'll start to see some change within that joint range of motion, and you would continue to see that as you continued with serial casting.
Thank you, Emily. Dennis?
I echo what both Kim and Emily have stated, and really in terms of the treatments and the pain, there is still, when you progress from spasticity to contracture, there's still that pain element that really needs to be addressed as well.
Yes, I think the difficulty in clinic, especially with severe spasticity, is you're not, with clinical assessments, you're not really able to differentiate between spasticity or contracture. And we don't have any, if any of you are aware, please let us know, but we're not aware of any objective assessments that are feasible to use in the clinic to actually measure contracture or spasticity. So I think that is the current limitation in practice and an area for innovation and research. I'll go on to the next question, which is, there are many questions around chemodenervation and about dosage and about what combination of drugs can work best. So perhaps I'll pose this question to Dennis. If you could comment on the efficacy of trials so far that have used botulinum toxin with combinations of tenazidine or baclofen.
So those oral medications are effective, but the side effects are very difficult to tolerate. And so most of the evidence looking at botulinum as a therapy in addition to something else is looking at one of those other treatments like electric shockwave therapy or casting and splinting, as Emily had brought up. Really, those oral agents, even in pain management, the pain, the gabapentins and the other drugs that we use to manage pain and spasticity are really causing fatigue and weakness and things that are not conducive to really improving patients' quality of life. So combining them with another treatment, you can maintain your dose of botulinum toxin and then use something else in tandem.
Okay.
So quick question, if we can clarify something. Imagine that my grandma is asking you, so about the treatment effect. So how effective is botulinum toxin? How effective is tizanidine? How effective is gabapentin? Are we talking about 400 patients? Are we talking about what percentages of improvement?
So with the botulinum toxin has been looked at in plenty of patients to demonstrate there is an effect. There is not per se an improvement in function. There is an improvement in the spasticity. So whether that translates to a functional improvement, there's a wide variability in the reporting because it's based on, that side effect that I talked about. If you over-weaken a lot of the muscles, they're not going to be able to function. Yes, you relieve the spasticity and for a large part the pain, but their function is not improved. And so that's why it's really not an ideal treatment. It is an ideal treatment if you're looking for, to improve hygiene or, be able to clean and take care of wounds and things like that, because you will relieve the spasticity. Tizanidine and those other oral medications, you really dose them until treatment effect, but then you might have those side effects that are not tolerated. And so, especially in the population of stroke survivors who are elderly, or greater than 60, those side effects are quite profound and really impact, again, their ability to function and have any kind of improvement in their quality of life.
Thank you, Denise. Very much appreciated. So at the end, my grandma, it will be, I have to say, got a long answer. It's not that easy.
It's not that easy. But there are other interventions that, not maybe, there are peripheral nerve blocks and things of that nature where you can block the sensory nerve, maybe not relieve so much of the spasticity, but she will have an improved quality of life, at least.
Thank you, Denise. I think it just shows to highlight that the treatment has to be personalized, and there have been questions about decision trees or algorithms where you can decide what sort of treatment intervention at what stage of spasticity. Do any of you, does the panel know of any validated decision algorithms or one that you use in clinic that you can recommend? Yeah, I haven't come across any either. I think there is much space for work in this area, which brings me to my next question to Emily. I think we all agree here that education is essential, and I like what you said, that it has to be early, consistent, and at many different parts of living with stroke, not always at the point of discharge. What do you think about the mode of delivery of education? I mean, traditionally, we've always looked at whether it's websites or checklists, but with the changes in time, what do you think about social media, and what other innovative ideas do we have around delivering education to the population on spasticity?
Absolutely, and that's a wonderful question. I do think that getting innovative using social media is very important, but I also think that there are a lot of people within within subgroups of our stroke survivors who aren't accessing social media, whether it's those within rural areas, it's those who are elderly or lower income. So I think we're definitely missing a large group if we're sticking to just those more innovative, right, catching up with where everyone else is. I think that it has to be something that, and I'm trying to think about the best way to say this, but I think it has to be something that when we think about our patients who don't have access, if they are seeing a doctor, it's going to be their primary care, right? So we need, as an entire medical team, we think about not just that specialized team, but when we think about early identification or getting appropriate referrals, we as an entire medical community, this is a conversation that we need to have. I've had many patients in the outpatient setting who have been referred to me, and the only doctor that they see is their PCP. Even after they've been discharged from the hospital, they've had no follow-up with a neurologist or a physiatrist, and that is their treatment team. So I think it's really important that we are able to have that conversation as a whole. And maybe it means that we need to target that education on social media to medical providers, and so that we can have that consistency across the board too.
Thank you, Emily. It's what I guess Gustavo's slide said about physician inertia. I think it all comes together, and it may not just be education to stroke survivors, but also to medical professionals, GPs, everyone else involved in the care of a stroke survivor. Thank you. Gustavo, do you have any other questions?
No, we are on the time. I think that there are many more questions also. So in the Q&A, some are related with other therapies that could be beneficial, and I encourage those the participants to contact us or the speakers directly. Anyway, I will turn towards Laura and thank everyone for being part of this. Thank you, the speakers, and Shamala for volunteer your work and commitments, and thank you very much. And please, the participants, complete the survey. Very important for us, okay? Laura?
Thank you very much, Gustavo. Just a couple more minutes from my side. Wonderful discussions, great presentations and questions. We have compiled all our resources and insights on the management of spasticity in this link. You can also scan the QR code with your phone. So here you will find our e-learning module on managing spasticity, our stroke checklist for HCPs and for people with lived experience, as well as recordings of past webinars on the topic of spasticity and more life after stroke resources. So make sure to check this link. Now, these are the other links for our site, our X account, as well as LinkedIn, which is where you will find our active channels where we promote our next educational activities. And lastly, an invitation to our next webinar taking place on March 26th on the occasion of International Women's Day on the very important topic of stroke in cis trans women, current data on clinical trials, hormonal therapies, and stroke prevention. We hope to see you all there, and thank you for participating in today's webinar. Take care. Thanks, everyone.
Thank you.
Thank you.
Thank you.
See you all. Bye.